Okay. Hello. Hi. Who is answering today?
Sir, I'm answering, sir. Tanmay here. Tanmay and Achint is there. Who else is there?
आपण कॉल करत असलेली व्यक्ती उत्तर देत नाहीये. कृपया थोड्या वेळाने पुन्हा.
Dr. Sharma, GRS, I think. Ganesh Sharma is there. So, Tanmay, you are answering, and Dr. Git, this thing, Achint is answering. Who else is there?
So, two people are answering, sir, today. Dr. Tanvi sir and Dr. Achint sir.
Okay. So today will be the last clinic for the case presentation, and after that we will have OSCE pattern so that we can cover all the tables and short cases, ward round. So that we will do after, I think, DNB exam, middle of October.
Swasti, can you hear me?
Yeah, हाँ बोल अच्छी.
हाँ सर, वो राकेश भाई तो है नहीं सर होस्ट में, पंकज महेश्वरी सर होस्ट है सर.
Okay. So Pankaj, you for the recording, he has been explained, na? He doesn't have to leave the meeting till end.
I'm unaware. Rakesh Yadav has logged in, but he is not the host.
सर मेरा नेटवर्क चला गया था सर, तो वो हो गया.
सर को बोलो ना एक बार आपको होस्ट बनाने को.
क्या? तो राकेश तेरे को होस्ट बना दूं?
नहीं सर, आप बन जाओ. थोड़ा सा नेटवर्क एरर आ रहा है, मैं थोड़ा ट्रेन में जा रहा हूँ. मैं रहूंगा मीटिंग में टिल एंड. तो ask Pankaj Maheshwari sir to make you host.
Okay, should I make you host?
No, Pankaj, you remain host, no problem. But at the end, if you leave then the recording will not be completed. So, बराबर ना, राकेश?
Yes sir, yes sir. सर बेटर रहेगा कि आप होस्ट हो जाओ सर.
अच्छा, ऐसा करूँ.
हाँ.
And so I should not be leaving the meeting, correct?
Yes sir, till end.
I have to end the meeting.
Yes sir.
जो भी होस्ट रहेगा लास्ट में एंड मीटिंग दबाना है.
हाँ तो ठीक है ना. अब तो पंकज है ना, पंकज विल अभी चेंज करने का जरूरत नहीं है. He will end the meeting at the end.
Yeah, I'll be there. Don't worry, I'll be there.
Yeah. And today
So,
is very interesting topic. Pankaj Bhai only has to, he and Gyanendra, these two are the people who are going to, uh, you know, take the exams or teach them. So
so
he has
where
to
is
be
the
there.
recording happening? Is it happening on my PC or anywhere else?
Yeah, this is auto recording, sir.
Okay, okay,
Recording हो
okay,
जाएगा. हाँ.
okay, okay. Fair, fair, fair.
Okay, so we just wait for 5 minutes more and then we start.
Sure. I think has Dr. Gite joined? I don't think.
No, we telephone kiya. I just telephoned him, but he has not picked up.
Okay.
मैंने just phone
Sir,
किया.
join, sir.
Sir, good evening all. Already joined.
Good evening. Good evening. Good evening, Dr. Gite.
Dr. Gite now has
just
become little busy because of his new. He has become a dean of Nasik. So very just 2-3 days back he has joined. So
sir,
anyway,
आप
congratulations to him for this new post.
thank you sir. अभी just दिन ऑफिस क्लोज करके घर निकल रहा हूँ.
चलिए बहुत अच्छा साहब. अब हम भी कह सकते हैं कि एक डीन हमारे दोस्त है.
नहीं,
Pankaj bhai, now you need to
लकीली
Mumbai.
वो आपका दोस्त जेजे में अगर डीन हो गया तो और ज्यादा जोर से बोल सकेंगे.
हाँ,
वही
मैं तो पूरा जोर लगाने को तैयार हूँ. आप बोलो क्या करना है.
Yes.
नहीं सर, क्या है कि भगवान ने जब डिसाइड किया है तभी मिलता है.
नहीं, बराबर है, बिल्कुल सही.
That will be the day. I'm waiting.
Yes sir, yes sir.
No, it
Yes.
is bound to happen. You see, that is what I was telling Dr. Gite, that at such a young age he has become dean. So अभी तुमने बहुत आगे जाना है.
Exactly.
Yeah.
That's true. The exams are in October, I think for 15th, 16th of October. You know, theory exams. So
12, 13, 14.
October and November, sir.
that is MCH is in November, December, na?
Yes, 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 sir. Yes, sir.
And this is in
DNB in
October. In October.
Yes, sir. ज्ञानेंद्र शर्मा सर ज्वाइन हो गए.
हाँ, ज्ञानेंद्र ज्वाइन हो गया है.
Sir, good evening.
Good evening, sir. Good evening, sir.
Good evening.
Now, Gyanendra ji, like last time, this is also a little tricky question case. So your advice will be really of a great help. So hopefully we have got two cases. One case is straightforward, but first case is little complicated.
Yes, yes. देखते हैं, sir.
Yeah, just give 2-3 minutes and then we start.
Yes, sir.
Okay, I think we should start now. Swastik.
Yes, sir. We'll start.
Yeah. Gyanendra ji, up.
Good evening.
Yeah.
Good evening, all the faculty members. Happy Teachers' Day.
Thank you.
The first case is a 5-year male child. Mother was the informant of the patient. Presented the complaints of frequency, urgency, dysuria for 10 days and history of fever off and on for 7 days. This was the history to begin with.
Yeah. So, Achint, now what are the important questions you want to ask?
Yes, sir. Sir, since this is a 5-year-old child and complaints of lower urinary tract symptoms, I would like to elaborate on the lower urinary tract symptoms so as to classify that those are storage symptoms or voiding symptoms. I would like to know about frequency, urgency, nocturia, and then overflow, and if patient is straining, and intermittency. And then, sir, I would like to elaborate the fever complaint in terms of is it continuous or is it intermittent, and it is high grade or low grade, whether there is an evening rise of temperature, and whether there is any history of any outside food intake, and these many, sir. Whether initially, previously, he had any history of any procedure done, any history of catheterization, and if any antenatal complaints are there, or patient during the antenatal scans, anything was diagnosed.
Achint, why did you ask history of evening rise of fever?
Yes, sir.
Achint, you
GUT
should have answer for every question you ask. Huh?
Yes, sir. Evening rise
So
of
there
fever,
must be something in your mind. Na? Just tell, you may be wrong.
it could be GOTB, sir, but in 5-year-old child, it is less likely.
It is very unlikely that a 5-year-old would develop. If you look at the pathogenesis of geotuberculosis, it takes at least 10 to 15 years. So to get the geocox at the age of 5 years is very, 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 very unusual. At least I don't remember any case report also describing it.
Yes, sir.
Yeah. So, Gyanendra ji, in such case, see, they are not coming across children
Yes.
much often. So, usually they ask a history similar to adult. So, will you like to tell them something different in history taking?
No, sir, what my suggestion to these students would be, complaint is fever. Primary complaint is frequency, urgency, dysuria, and fever. So now automatically, now if the complaint would have been only fever, then whether it is urological or non-urological is a different story. But it has started with frequency, urgency, and dysuria, and then there is fever. Then the entire gamut of thought process would be restricted to the urinary tract.
Fine.
Whether it is pyelonephritis, cystitis, or stone disease, because even in a 5-year-old, stone with fever is known to occur. So these are the common things which are likely to come to anybody's mind.
Fine. So, Tanmay, you want to add anything, or you any negative history?
Sir, I'd like to ask history of pyuria, hematuria, lithuria, history of flank pain, any history of previous urinary tract infections, the birth and antenatal history, along with history of immunization.
Okay. Fine. So, Swastik, can you just go ahead?
Yes, sir. So fever was a high grade, associated with chills, no cyclical variation or evening rise, and fever responded to medications when taken, sir. There's no history of hospitalization in the past and no significant medical history. Gestation and birth history, normal maternal history during pregnancy. Gestation was full term. There was no history of oligohydramnios. Labor was normal. Normal vaginal delivery was done. No use of forceps or instrumentation during the labor. Neonatal history, normal Apgar at birth. No NICU admission or no hospitalization in the perinatal period. and we could not get the perinatal scans for the patient at on presentation. Those scans were not available in the patient. All milestones were reached normally till date. Immunization has been done as per schedule. Presently in preschool, no history of enuresis, temper tantrums, pica, thumb sucking, etc. He was breastfed till 1.5 years. Normal feeding started and tolerated. Normal weight gain pattern was there till presentation. No history of headaches, unconsciousness, ENT infections or tonsillitis. No history of sinuses or dyspnea. No history of discharge, abdominal pain or previous infection as such. History is not contributory. So should I go ahead with examination?
They want to ask anything? They want to?
Hello.
Any other question is left? Achint or Tanmay? Otherwise,
No, sir. I think we can go for it.
Bowel dysfunction.
Well, yeah.
so that part you have forgotten, which is very important. Okay. So now next, what Tanmay? What you want?
I'd like to do a general physical examination with the focused abdominal and genitalia examinations.
Okay. Yeah, Swasti, go ahead.
Patient was conscious, cooperative, oriented, time place and person. Pulse rate was 110 per minute. Blood pressure was 90 to 50 millimeter of mercury. Respiratory was 18 per minute. Afebrile. At present on examination, saturation was 90% of room air. There was no evidence of pallor, icterus, sinus, clubbing, edema, or lymphadenopathy. Spine examination was head to normal. For abdomen inspection, flat abdomen, centrally placed inverted umbilicus was there, normal abdominal circle respiration was there, skin was no scars, sinus or directed veins, no visible swelling, no visible peristaltic pulsation, 100 sites were clear, external genitally circumscribed and normal. On palpation, normal temperature, no tenderness, no palpable lump. There was no cough impulse on examination. External genitalia, as told, circumscribed, no abdominal detected. Spine deformity, no deformity or tenderness. A question
Can you go back to the previous
tympanic
slide?
node.
Please, can you go back to the previous slide? Before this. Okay. Yeah, okay. Yeah, you can continue.
Spine examination.
So normal, sir.
No, head to head. There is written head to toe normal. तो ये यहाँ चलेगा, वैसा नहीं करना है वहाँ.
Yes, sir. Okay, sir.
Another thing is, basically, this child has symptoms related to the bladder. All three symptoms are storage symptoms. So something is wrong with the bladder directly or indirectly. And when it is associated with the fever, that means somewhere there is an infection. So that definitely should come in your mind primarily after listening complaints only. So what are the probable causes of the bladder involvement associated with fever in a 5-year-old child? This is a theoretical part. That should become in your mind. For example, if same patient had previous recurrent admissions, that may be VUR. For example, if cystitis of any cause, that if it is associated with some widening symptoms, there should be a distal abscess. It can be simple phimosis associated with infection. So that's how you think in your mind. If the patient come in the OPD or in front of you, all these three symptoms immediately came in my mind. All three symptoms are related to the bladder. They are not related to any other thing. So how bladder gets involved? And it is associated with fever. If you think basically, think by basic way, you end up into some diagnosis.
In 5-year-old, you have written about DRE. So how will you do DRE, and is it very important?
So I'd like to, if I do a DRE, I'd use a little finger and do the DRE after taking adequate consent and if the patient is cooperating. It is necessary to mainly to rule out impacted feces in case we're suspecting a gallbladder dysfunction that could lead to a cystitis and these symptoms in that case.
Yes. And what else? Even the very legs, sphincter.
Yeah,
or
yeah, a neurogenic bladder also in case maybe you're suspecting some spinal deformity and.
Fine. Okay.
Sir, another thing, it mentions he's circumcised. I wanted to know if it was a ritual
Yes.
circumcision or a surgical.
Sir, ritual, sir.
Okay. Okay.
Solution, sir.
Swastik, go ahead.
Sir, rest of the system examination are normal, sir. Chest was clear and cardiovascular system are normal examination, sir. No positive finding out of all this, sir. Go ahead. Should I go ahead with?
Yes, yes.
Genitalia was normal, sir, bilateral.
Yeah, go ahead.
Sir, investigation, sir. Next,
So
I have
no,
got
let them ask.
investigations too.
They want to know anything else. Achin, do you want to ask anything, any important investigation, this thing, or you want to go ahead?
Sir, I would like to go ahead with investigation.
So what are the basic investigation you want to know?
Sir, firstly, urine investigation, urine routine micro, and urine routine culture also, and then basic investigation of CBC, serum creatinine, and one ultrasound QOB, ultrasound abdomen and pelvis with QOB.
Swastik, can you show them?
So it was investigated initially with CBC, serum urine routine and culture sensitivity. Initial investigations revealed hemoglobin was 9.0, counts were 12,300, and platelet count of 293,000. The creatinine was 0.77. Urine routine examination showed pulses 40 to 50 per high power field and RBCs 1 to 2 per high power fields. Urine culture sensitivity showed Pseudomonas aeruginosa was treated as per sensitivity. Should I go ahead, sir? And
creatinine is normal.
Achin, do you think that serum creatinine is normal in this case?
Serum creatinine for a 5-year child is raised, sir.
Okay. So now next, what you want to do? He has to show you sonography. By show sonography.
Sir, we got the sonography. Sir, written report was there on the paper, sir. USG KUB was hydronephrosis, hydroureter, thickened urinary bladder wall 4.7 millimeters. Sir, nothing else was significant in that sonography report, sir.
Fine. So now these are the reports. Tanmay and Achin. Next,
So
you tell us.
So the patient has a raised creat with increased counts and an obvious urinary tract infection with Pseudomonas. Along with that, left hydronephrosis, hydroureter, and a thickened urinary bladder wall. So currently, I'll be thinking in terms of either a cystitis secondary to bladder wall dysfunction or neurogenic bladder that has led to a secondary VUR or a primary VUR with a superimposed cystitis would be my top two differentials for this case.
Would primary VUR be your first diagnosis or it would be a secondary VUR?
It will be secondary in this case because mainly patient has come with the voiding dysfunction, sir.
But voiding, what are these voiding dysfunction?
As in frequency, nocturia, and urgency.
Right. Can this be because of infection?
Yes, sir.
So infection can be because of
primary VUR also. Yes.
What is more common, primary or secondary?
Primary, sir.
So put the common diagnosis first.
Yes.
And also the history is just 5 to 7 days.
Yes.
Yes.
So when you say voiding dysfunction, that would be a long history.
Yes.
Right.
Suppose you are there as a consultant and this child has come to you with a written report of ultrasound, this and the lab reports. What would you do?
So ideally, I'd like to do an ultrasound myself and confirm these findings.
Right. So what are the things you are likely to look at in a sonography? Or in
Firstly,
other words, what are the things this report is not mentioning?
Firstly, the capacity and the post-void going from below upwards, capacity and post-void volume of the bladder, pre-void and post-void volumes, whether there are any internal echoes seen, whether
I will give you. Pre-void is 70 ml. Post-void is 30 ml.
in a
What is the
5-year-old,
normal capacity, bladder capacity for this age?
in 5-year-old, it will be 210 ml, so age plus 2 into 30. So that is 210 ml. So this will be a low capacity bladder with the post-void residue being more than 1/3 of the pre-void capacity in that case.
So you are very sure that this will be a low capacity bladder?
No, sir. USG again is not a sensitive test, and because of cystitis, chances of cystitis being there, the
Very
capacity
good.
will be reduced.
Yes, that is exactly the reason these children are voiding very often, because of presence of infection, and you will not get a clear idea. Your interest would be more in the post-void residue.
Post-void residue, yes.
Then any other thing?
Posterior urethra, if it's dilated, just
very good.
And then along with that, the ureteric jet, if I'm able to visualize within the bladder, so that's all in the bladder that I'd like to see. Then the ureters, if they are dilated, the renal pelvis, whether it's dilated.
Suppose the ureter is dilated, what would you do if it is dilated? Anything, you would be happy with the report that it's a dilated ureter, or you want some more information as regards that dilatation?
The diameter of the dilatation I would like to know, and whether there is any tortuosity could be appreciated, which is
okay. So define a mega ureter.
More than 7 centimeter dilatation, 7 millimeter dilatation of the ureter.
In the lower ureter. So in 7 millimeter. So if you are looking at the dilated ureter in the lower part, one should ideally always mention what is the diameter that you have measured. Yes. Then
same thing in the pelvis, sir. How much it is dilated, grade of dilatation, along with the anteroposterior renal pelvis diameter. Whether there is whether the major and minor calyces are dilated as well, whether there's parenchymal thinning, how is the corticomedullary differentiation, and any photopenic areas if they're present. Sorry, not photopenic, hypoechoic areas they're present in the cortex.
Okay. Right. So, okay, you have got this left-sided. They have mentioned that the pelvis is dilated. There is hydroureter. There is dilatation of the calyces also. The parenchymal thickness in the poles is around 4 millimeter. In the mid pole, in the upper and lower pole is about 4 millimeter, and in the middle pole it is about 6 to 7 millimeter. And the dilatation of the lower ureter is dilated with a diameter of about 12 mm. Now what next?
So in this case, as the patient currently has an active infection, I'd like to treat it initially with antibiotics. And then proceed with after confirming that after 1 week of antibiotic course, after 1 week after the completion of antibiotic course, I'd like to proceed with the micturating cystourethrogram.
Why don't you want to do an MCU right now? एक हफ्ते के बाद पेशेंट नहीं आया तो क्या करोगे?
There is chance of the infection going, introducing worsening of the infection if you're doing it. But it can.
There are
It
two
can.
reasons why you should
Anything
not
other
do
than
it.
that?
Other than that, the MCU will exaggerate the reflux as well. So, sorry, the infection.
Non-existent reflex will be
Yeah,
seen now.
would be seen. Yeah.
Yeah.
Right. Okay. So after a week, he comes back. Patient is absolutely fine. And then you want to have a VCUG or an MCU.
Yes.
Okay. Can you describe how you would do an MCU in this child?
So after adequately treating antibiotics, I'd like to insert a perurethral the small bore catheter and infuse
What is the
around
smallest catheter you know of?
8 French.
6 French Foley is the smallest catheter.
Okay. Okay.
So you would like to introduce a Foley?
I would prefer. We usually use a infant feeding.
So mention that what you have been doing, you tell it.
Yes, sir. We prefer using a 5 French infant feeding tube in these small children.
Correct. So what you have done, mention that.
Yes. With that, we know the age, the capacity as per age is 210 ml. So around 75 to 80% of that will be around 150 to 170 ml of bladder filling I'd like to do. And with that, I'd like to take, first I'd like to take a scout film before that. And then after filling the bladder, I'd like to take images with a full bladder, remove the catheter, ask the patient to void, and take during the voiding phase and a post-void films.
Do the patients void on command?
No, sir. This age
Most
group.
of the times it doesn't. So for a small child, if you are filling the bladder, say he's a 2-year-old child, 5-year-old is able to communicate, but he's a 2-year-old child, he will not communicate. They keep on crying incessantly. How will you know that the bladder is getting filled adequately? The capacity is very erroneous if there is presence of reflux. So what are the signs which tell you that this bladder is getting filled and it's time to just wait for some more time rather than filling it more?
Firstly, the ease of which the flow of the contrast will go through the catheter in the bladder, that will slow down. Also, the patient will have increased restlessness as the bladder approaches the capacity. And
one of the very good signs is that if there is upgoing of the toes, yes, that is a very good indicator that the bladder is getting filled. If you have done enough MCUs in children, you will get a fair idea about these small little things. And there is started, then you were very right in mentioning that you would use a 5 French infant feeding tube because you can start getting some leakage by the side of it. So
yes.
that is the time, because see what happens, the person who is there with the infant feeding tube, it is never getting filled with gravity. It is always somebody is pushing it. And the moment these things, you see the upgoing toes, some leakage by the side of the catheter, the person removes the infant feeding tube and the technician who is there, he immediately shoots it the moment the stream comes.
Okay.
And even I think in children, we can see the suprapubic fullness also, correct?
Yes, yes. Yeah, Tanvi.
Yes. So in these films, what I would like, I wouldn't like to over-distend, especially in this, because that might lead to an erroneous result. And things I'd like to see is the capacity of the bladder whether there is any presence of reflux with either whether it is active or passive. The grade of the reflux I'd like to see. Then also I'd like to see whether there is any fornicial blunting or loss of papillary impressions.
That comes in the grades of reflux. So let's see the MCU if it is there.
This was the first scan that was MCU scan was done, sir, in this patient. After the symptoms and scores of antibiotics. This was the first scan, sir.
Can you just analyze them and show them? It is possible? Yes, Tanmay. Just say
Yes, sir.
whatever you see better.
So in these images of plain full bladder straining and during voiding oblique images, the bladder appears to have a good capacity with no reflux seen in either straining or voiding, with good with no obvious urethral obstruction also noted, and no post-void residual volume in the post-void fence. So I would actually say this capacity is a little higher than normal.
Why do you feel so?
It's occupying most of the pelvis and going beyond. Usually,
But in children, it is an abdominal organ. Huh?
yeah. Yes, sir.
I don't think it is the extra large bladder.
No, it appears normal.
Yeah.
Normal study.
But Granny, do you think there is a little dilatation of the posterior urethra?
No, sir, no.
No, no.
No.
Fine.
Sir, if you have seen carefully on left side, in the area of kidney, why there is something white shadow? Can it be a reflux? Second film.
Just show that. The lower down.
So, but then there's no contrast going into the ureter that is appreciable corresponding to that.
Okay.
So if you have seen a dynamic image, then only you can see ureter, or there should be a column of contrast in the ureter to visualize the ureter as a reflux, or complete ureter as a part of reflux.
Yes.
And the part of ureter behind, as it is a distended bladder, the part of ureter is majority, lower part of the ureter is behind the contrast of the bladder, overlapping. So in the gaseous shadow, last picture, now the picture shown mid picture, the gaseous area, behind that gaseous area, some whitening is there. Why that whitening, I also don't know. Exactly, it is in the tip of 12th. Yes.
Yes, I got
just mid.
But Dr. Gite, I think it is a bit too anterior.
Sir, ये actually
Oblique film है. Yeah.
टिप ऑफ 12th रिप के वहां पे गैस है, 11th एंड 12th रिप के बीच में, हाँ वहां पे, तो वो कुछ व्हाइटिश एरिया दिख रहा है जो कि बाकी एरिया से अलग दिख रहा है, डेंस दिख रहा है.
I would feel in this oblique film, the kidneys will look a bit very near the spine.
Yeah, Pankaj agreed.
So
May not be, but
yeah, maybe.
dicey hai,
Yes,
pata
yes,
nahi.
yes. And as you rightly said, we have to look at in the dynamic images. Static images में
Yeah.
कहना बहुत मुश्किल है.
Okay, we will go ahead with without
go ahead.
as it is without reflux. No issue.
Yeah.
Sir, to continue with it, patient had recurrent urinary tract infection. Patient was admitted to the hospital and antibiotics were given and an MC was repeated in that case, sir. And
No,
on
question arises कि why he has a left hydronephrosis. Because your primary more commonly suspected diagnosis is ruled out by this picture. If it is negative,
Correct.
then why there is a hydronephrosis? So we have to think, in spite of going back only and banging on the VUR diagnosis only, think other diagnoses also.
What is the next common possibility?
Achin, Tanmay, you can also answer. Tell us.
So considering it's only a unilateral disease, I would not suspect any vesicle or intravesical causes particularly here, because that will be more common as bilateral. But then I'd like to keep them lower down in my list. When it comes to upper urinary tract, I'd like to consider the diagnosis of a congenital megaurator that would have caused this. And otherwise, maybe but then I would consider possibility of stone, but that should have been visualized in the ultrasound at the UVG. Again, that's quite rare.
Can it be a wall?
So posterior retrograde also.
Yeah,
that with the pop of unilateral reflux could be a possibility.
But MCU में लग रहा है PU wall में.
Yes, that would have diagnosed that.
और PU wall में pop off में आपने VUR बोला तो VUR तो नहीं दिख रहा है.
दोनों नहीं, correct.
ये है ना, वो गीते सर आपको फंसा रहे हैं.
So the next common diagnosis what sir has asked is theoretically and practically it is a primary obstructive megaurator.
Right.
It may be it can be non-reflex.
Yes.
It can be reflexing, it can be non-reflexing. So various type of megaurator. So megaurator रह सकता है. तो अपना डेविएशन चेंज नहीं करने का. Examiner कुछ भी बोला.
And another thing, Tanmay, you have been answering pretty well till now. See, when you are asked something now, what you need to be smart enough to read the examiner's mind. Like Gite sir asked you what is the possibility. So you started by saying infravesical cause is unlikely because it is unilateral. It is unlikely. That is, what is more likely, mention that. What is unlikely, वो बाद में छोड़ दो. एग्जामिनर्स को बहुत पेशेंस
नहीं, उसने इंफ्रावेसिकल बोला इसलिए मैंने पोस्टीरियर वाल बोल दिया.
हाँ, और वो बराबर उसको फंसाया आपने.
ठीक है, how will you proceed now? Because we don't have any diagnosis right now.
Yes.
But there is a hydronephrosis.
So I'd like to, after treating antibiotics, I'd like to repeat the creatinine and see if it stabilizes. Then go for a CT scan and see if there is any stone or anything.
I knew you would say CT scan. Why do you want to have a CT scan?
In this case, because there is no obvious VUR, so I'm thinking in terms of an obstructive pathology.
So if I can, you are thinking in terms of an obstructive pathology. How will CT scan confirm that diagnosis?
So my top two diagnosis being either stone or a obstructive megaureter, it can
You have
definitely
done a
rule out.
sonography. I had asked you right at the beginning what you would like to do, and you were very correct in answering that I would do a good sonography again, where you mentioned everything.
Yes.
तुमने तो stone rule out कर दिया.
Yes.
See, in an adult, okay, all these things you can see, but in children it will be difficult.
And while telling the contrast CT scan in the pediatric age group, think twice. If it is really indicated and if you can able to defend that, then only tell the CT scan.
Most
Otherwise,
people,
examiner will ask 1,000 questions.
अरे वो they will start asking you कितना radiation dose जाता है,
हाँ वही
उसको आगे लगेगा,
unnecessary वो फंस जाएगा वो।
हाँ,
फिर एक एक्सरे में कितना रेडिएशन, फिर आईवीपी करने का तो क्यों नहीं किया, फिर सीटी क्यों किया, उसका कितना रेडिएशन, अननेसेसरी अपना प्राइम यूरोलॉजी छोड़ के रेडियोलॉजी शुरू हो जाएंगे।
correct.
So Tanmay, can you just keep this patient under observation and just follow up? Is it possible, or you want to definitely do something, find out the cause and want to go ahead with any other treatment?
Because there's so much dilatation of the system, Sir said, considering the report, Sir said with a 4 mm thickness at the poles, and that I would like to see what is
No,
causing
that is what he
it.
told you, theoretical.
Yeah.
If you
Otherwise,
see
if it's
in
otherwise, if
sonography, they have just see sonography, beta. No.
This sonography is only 2 lines, left hydroureter
only left
nephrosis and
hydroureter nephrosis.
cystitis.
In that case, I'd like to give antibiotics, treat the UTI, and then follow up and see if he has any recurrent episodes, and whether the hydronephrosis subsides after 2 or 3 months. We can repeat a USG. And,
so you want to repeat the USD and you want to find out whether infection is still there or not, correct?
Yes, sir. Yes, sir. Yes.
Okay. Just show that it is there, done. We have done it. Sonography, it was done
Sir,
second time.
Sir, in this patient, sir, they had done a DMSS scan and they had done a DMSS scan, sir. And then they had gone ahead because patient was having a recurrent UTI. Again, a repeat MCU was done, sir.
Okay. So Gnanendra ji, this patient had actually come to us later on. So initially, because of wherever he was investigated, they did DTPS scan, and since patient had an infection, they again repeated MCU.
Yeah, sir, it has been done. See, but like if this case would have come to me, my first priority would have been to get a good detailed ultrasonographic examination done. Because primarily whatever was available was only left hydroureter nephrosis, which doesn't give much idea.
Right.
So knowing the grade of hydronephrosis, amount of hydroureter, presence of internal echoes and everything, those things would have mattered to me a lot, because a good sonologist would tell me the diagnosis to a large extent. I have seen a good sonologist even telling that this is unlikely कि इसमें reflux रहेगा, this is likely to be obstructed. They can even pick up the tapering of the ureter over there. And if not, they would say कि yes, it is opening, or in a male child, it could be an ectopically opening ureter also. Thinking of a rare possibility. So a good sonography would have given me everything.
Correct. No, I agree. And the Sharma, the thing that because you are regularly doing pediatric surgery, urology practice, that is why you have got a sonologist who understands you. He understands what you need, and he's doing accordingly.
This is something which you have brought very important point, that in a pediatric case or in pediatric urology, having good sonography backup is of paramount importance. It makes your life very comfortable. And for the students also, once they are going to come in practice, they will have to catch hold of a radiologist, tell that person what we want, and stick to that person so that they also get tuned to your line of thinking. Otherwise, sonologists are most of the times in such a tearing hurry कि वो ऊपर और नीचे देखते हैं. Bladder wall thickened, bladder suboptimally distended, ऊपर hydronephrosis, report खत्म within 2 minutes.
Yes, and second important.
In a primary report, have you asked for any scars?
Yes, sir. In the first thing
So there are no scars.
there was nothing mentioned in the first USG. There's nothing.
So you should have asked now. Your diagnosis is VUR.
Yes,
If suppose there are some scars is given in sonography. So that is another indirect way to go for repeat MCUs.
Yes.
And I had given you a hint when I said that the cortical thickness at the upper and lower pole was 3 to 4 millimeter, and in the middle pole was 7 mm.
Yes. So that was polar scarring.
That means sir is indirectly giving the hint. That hint has to be picked up.
Yes.
Fine. So what we have learned in today's presentation is, number one, that you should have a good rapport with ultrasonologists, mainly for the pediatric cases and even for the adult. Second thing, it is always advisable for you to go. Just don't leave the patient. Better to go with the patient and see yourself that what are the findings you want, so that sonologists can also pick up, and to remain to the same sonologist so that over the period he becomes master in diagnosing and whatever you need in that patient. So that is the most important thing. Now,
early part of my practice, then I used to write down, to whosoever I used to refer the case for sonography, I used to write down, I am interested in looking for 1, 2, 3, 4, 5. So all those things come to you.
Yeah, very important. So fine. Now, Tanmay, look at this. They repeated. What are the things you are seeing in this? Please tell us.
So firstly, the
Please mute whoever is there.
yeah. So firstly, the is the first one in. Okay. Firstly, there's an irregular contour of the bladder I can see in these particular films. And with the full bladder itself, there is reflux suggestive of passive reflux, which is, I'd say, grade 4, which is persistent on the. This is on the left side, which is persistent on the avoiding film, and post-void. In post-void, I can see a high-grade reflux on the right side, which is not there on the initial films.
Anything else you can see? So you can see the left-sided reflex in first 2 films. You can see right-sided reflex, a little hazy film in the third
Yes,
side.
sir.
And can you see anything else in the second film? Don't you think, compared to the first MCU and second MCGU, what do you think? There is a difference in bladder?
Yes, sir. The bladder contour is changing.
And can you, in the second film, can you see something?
The trabeculations are there in the bladders.
No. What is that on the top of the bladder?
A divertic.
Is it a divertic? Is it a contrast which has come out?
Yes, sir.
And
So
is
little
it
extravasation towards the right. Towards the right on the dome.
And it is coming out to the skin. Just see.
Yes, there's pooling of contrast towards the right side of the abdominal wall.
So Swastik, just tell them what had happened. So they thought that it is a urachus, okay, which is filling up, and 2 days later, patient had pain in abdomen. So he underwent cystoscopy, and there was a rupture of bladder at the dome of bladder, which was noted. So Foley's catheter was kept, and conservative trial was given. Now this is a scenario. So now this is what happens. Why it happened?
Possibly because of high pressure voiding that the patient was having.
Pardon?
It could be overfilling of the bladder. That would be the
Number one.
possible
Number two.
cause. Or
Probably it was done under GA.
Yeah, under anesthesia if you're doing, so there won't be any sensation that any signs of bladder filling that we had seen earlier.
Second, someone might have put excessive pressure on the abdomen. And third, there may be, because of the infection, there may be inflamed bladder.
Weakened wall of the bladder.
So all the one, that may not be a one cause, there will be a multiple causes, no?
Yes, sir.
So now what you will do?
This, sir, usually tends to occur because there is a tendency on part of a lot of people that they tend to do a scopy in these patients and do an MCU under anesthesia.
Correct.
Now, I personally never agree to this MCU under anesthesia. It should ideally not be done under anesthesia. If I'm not wrong, the 6th edition of Campbell had mentioned that it should not be done under anesthesia. And when it is done under anesthesia, it is always short GA under which it is done. So the anesthetist is in a hurry. They fill the bladder and the patient is not voiding. They apply pressure.
Correct.
And this happens.
Yes. Fine. So now what you will do? Will you do cystoscopy in such patients?
No, sir. I'd like to, if it's an extraperitoneal rupture, I'd just like to catheterize and come out in this case. Sir.
Hello. Let me ask you, how would you differentiate an extra and intraperitoneal rupture on an MCU?
The way the contrast is going, and if I can see the outlines of the bowel, that's more likely an intraperitoneal rupture, or a presence of a flame sign, or the contrast going away from the superior part of the bladder. That would be more typical of an extraperitoneal.
So when it is being done under an MCU, it's a distended bladder.
Yes, sir.
What is more likely to happen?
Intraperitoneal.
I think given the expression cystogram that is done under general anesthesia, extraperitoneal perforation will be very, very unusual. It will invariably be intraperitoneal.
Intraperitoneal.
Yes.
So in this case, now it hits rupture. I think it was outside.
Actually, if you see the second film carefully, whenever the contrast is taking the contour of the bladder, like it is just perivesical collections, like in rim of the contrast, if it is taking at least half moon shape or totally covering the edges of the bladder, that is usually is the extraperitoneal. And when the contrast is going along the length of bowel or towards the right paracolligator or left paracolligator, in such situation it is intraperitoneal rupture. Usually, as sir told, if it is used, if it is the MCU is done with the Credis manual or pressure on the suprapubic area, in such situation, the majority times it is intraperitoneal rupture. And whenever there is intraperitoneal rupture, the conservative treatment usually is not indicated. There are few literatures which suggest the intraperitoneal rupture also can be treated conservatively in a properly selected cases. Extraperitoneal rupture, yes, it can be considered, but it should be confirmed. It is extraperitoneal rupture.
One more question. Why are you seeing contrast in the right kidney in the last image?
Reflux is there. It's a grade 4 reflux.
I think it is not reflux, it is absorption and opacification of the PCS.
Oh,
Yes.
Reflux we
yeah.
were suspecting on the
Following the
left
X-ray,
side.
yes, yes.
Correct.
So
Very true.
this is the in a way a IVU image because
Yes,
of
sir.
interperitoneal absorption.
Yes. Yes, sir.
Agreed, sir.
Fully right.
Swapnil, you need to close.
I think even the last third film, it is showing the bladder. Probably it is not the dye inside the bladder mainly. I think it is even the
Around.
as it is extraperitoneal rupture of the bladder. So the dye may be all around the bladder, and that is why we can see the hazy bladder.
Yes, I agree. That's the very diffuse and hazy image. So in all three images, from the first image, we can see indirect signs of bladder perforation very clearly seen in the middle image. And last image is showing because of absorption of contrast and opacification of right PCS.
Yeah.
And probably some amount of contrast has come from the right kidney to the bladder. Left kidney is not opacified, which indirectly shows that left side
Decreased
function is reduced.
Yeah. So in this case, what you will do? Forget what they have done. What you will do?
If it's extraperitoneal, I'd like to go for conservative management with catheterization. And I'd like to wait for 4 to 6 weeks and do a repeat cystogram to see whether it is healed and then proceed with further management for VUR, sir. In case we establish by chance that it's an intraperitoneal rupture, I'd like to explore and repair the bladder primarily.
Yeah. So just show Swastik what they did, what they had done.
Yes, sir. So after the trial, sir, they again repeated one MCU, sir. And after this, they went ahead with surgery, sir. They went ahead with surgery for the repair, sir. And this was the OT note, sir.
You just read them.
A financial incision.
So urinary bladder was identified. It was open. It was trabeculated. Mucosa was infected, and it was diverticulum was noted with sealed
I will
off.
read it, sir.
Yep, just read it.
Yes, sir. So, yes, sir. So trabeculated mucosa with infected urethral diverticulum noted with sealed of chronic perforation. Bladder was closed in layers, and perforation on the dome of bladder required with a repaired with a patch of adjacent urethus, and hemostasis was achieved. This was the
Okay, fine. And they had kept a perurethral catheter, correct? Yeah.
surgery. Patient was conservative and kept on Foley catheter. Foley catheter was removed later. After removal of Foley catheter, patient noted a leak from the financial incision site, and then a diagnosis of a vesicoperitoneal fistula was made, sir.
Okay. So Tanmay, this is a case. Now you know, initially it had not shown any reflux, only the left-sided hydronephrosis and hydroureter, correct? And
Yes, sir.
MCU was not suggestive of like a typical posterior valve or neurogenic bladder. And there was first time there was no reflux. Second time they did it, probably they might have done under anesthesia, might have applied the pressure on the bladder, and there was showing reflux on the left side, but patient had extraperitoneal rupture of the bladder, and they suspected that it was an urachus. So probably from the urachus, it had ruptured. under force in the infection. We are not sure. We are just contemplating whatever we assume. And as you can see, the dye was absorbed, and from the right side, he was excreted, and you can see the dye all around the bladder in the third field. So they tried conservative, failed, and they did exploration. They had closed the bladder in layer. In this case, the question is, you will only close the bladder, or you like to put the suprapubic?
In this particular case, I'd like to go for a suprapubic. Actually, in our institute, we use suprapubic for every bladder perforation. But yeah, in this case, especially since because of the mechanism of injury, I'd like to ensure that we keep a suprapubic in order to prevent further complications.
So, Gyanendraji, can you just explain how to manage such cases?
Perforation, sir, bladder perforation.
Yeah, in this case,
we till this point, I think what they had to explore, that was true. But as you very rightly said, I would have put in a suprapubic and kept him for a very long time and put the patient on bladder relaxants also. Because the very fact that one MCO is not showing reflux and the other's MCO is showing grade 4 reflux, it can happen, but the contour of the bladder is different. And the way it has perforated suggests that this bladder is also not doing well. So bladder relaxants and SPC would have been mandatory as far as I am concerned.
correct. So now at this point, patient came to us. He had leak from the suprapubic wound. Already operated once. Already they had done the suturing. So now next what? Tanmay, now this patient has developed this leak and he has come to you. Now what you'll do?
The first thing I do is maintain a empty drained bladder and catheterize the patient. Start. I think he'll need antibiotics again because his development of fistula. Do all the total counts and renal function tests, and stabilize the patient initially. I'd like to keep him on catheter for at least 6 to 8 weeks, and then repeat a cystogram and ensure that the fistula is closed before giving him a trial of void.
Okay. Gyanendraji, the advice?
Sir, once he comes to me with a vesicocutaneous fistula, I know things are not good. Why there is a fistula?
Right.
We look at the causes of fistula. So either there is persistence of infection, epithelialization of the tract is unlikely to occur, so persistence of infection, or there is some problem with the bladder which is not emptying, because vesicocutaneous fistula developing usually is secondary to infection or if there is a bladder pathology. So Tanmay is right when he says that you will need a bladder drainage. But this bladder drainage will be needed for a very long time. This is unlikely to subside most of the times within 5 to 7 days. So yes, primarily nobody would put an SPC. We would start with a periurethral catheter, maybe take the urine for culture, give culture specific antibiotic, and hopefully over the next 5 to 7 days, if the fistula closes, as he said, I would also repeat a cystogram and see whether things are absolutely fine. But if it is not so, then it would be better to put an SPC in this patient so that you ensure a long-term bladder drainage without affecting the urethra, and at the same time continue with bladder relaxants.
Okay. So he was on a catheter for a very long time, almost more than 2 to 3 weeks, but still there was a continuous leakage from the wound.
Usual story.
And that wound was not appearing good. So I'll tell you what just show. This was done outside and patient had come to us.
So patient come with the films only, sir.
Yes. What are the findings?
There is a thick-walled distended bladder, sir, with uh, on contrast film. It's a contrast and CT. So there is a good enhancement and contour of the left kidney, whereas the right kidney shows decreased contrast enhancement compared to the left one, with the hydronephrosis, and the upper pole there appears to be thinning of cortex. Oh, sorry, no, that's a pelvis. A dilated pelvis, which is going into a dilated ureter, with a thick-walled bladder, which appears to be distended.
Okay. You ever got a report, Swastik?
Only patient came with the films only, sir. We did not have the reports.
Okay. So now next what? Tanmay? I'll tell you what, because the wound was not appearing good, and I thought that suprapubic, may not be, it may cause a little more damage. I wanted that part to heal up and infection to go away. So what we decided to do a cystoscopy and do bilateral PCN. Just show the film, just show the, yeah. So can you see?
Yes.
This is the large dilated ureteric opening, sir. And this is the fistula, sir. This was the fistula side, which was coming out. And
So
the
what
bladder
we have done is
small, sir.
we have identified the bladder fistula where it is, and we have both the ureter were dilated, and they were, on cystoscopy they were appearing like a refluxing. They were not appearing normal, as you can see. So at present we have done whatever came to my mind. I thought that I'm not very happy with the abdominal wound. It was quite infected, the whole abdomen, because of like almost 1.5 month patient had a suprapubic leak continuously. So the abdomen was also not, wound was not good. So I decided to do bilateral PCN. So we have done at present bilateral PCN. So Gyanendra, now, just now a patient will be coming back to us. Can you tell us now how to go about?
सर शांति बहुत दिन रुकना पड़ेगा. This wound will take a long time to heal. Sir, I will tell you a patient which I had seen long back. He had undergone a reimplantation for reflux. 2.5, 3-year-old child. And he came to me on the 10th day, reimplantation done somewhere. On the 6th day, patient had fever. And then there was some collection, and then there was leakage of urine from the phalansteal incision. In a matter of couple of days, the entire wound opened up. Initially, the skin subdued, then the rectus, and then even the bladder opened up. So, like, this was an infected system. And as you, if you remember, in this case also, right at the beginning, it was Pseudomonas infection.
Right.
Nowhere it has been mentioned that the infection had been eradicated. So it is possible that that infection persisted and then it becomes very, very aggressive. So in the case which I had seen, the boy, virtually the bladder also had opened up.
Okay.
So I did not do anything for a very long time. See, ultimately it is a question of drainage. So I
Right.
said, forget whatever has happened to the reimplantation. But in a child, you end up doing a vasicostomy. This is a very bad vasicostomy that has happened.
Right.
We waited for nearly 2 months, antibiotics and everything. Of course, once the bladder opened up, his fever and other things subsided. And then after 3 months, what was needed was a very small closure of the bladder, and the wound overall healed up very quickly later on. So it will need an aggressive management of the infection and patience till the wound heals up.
Okay. So now we should wait only for everything to heal up.
Usually such cases, sir, one should try perioral catheter for longer time. And if it is not healing, then what should be done is to explore the thing, close the perforation, place the SPC, place the perioral catheter, give proper antibiotic, and wait. That will definitely help. That's what we usually feel in our practice.
Yes.
Yeah. So we waited for almost more than 3 to 4 weeks, but still it was leaking. So anyway, now at present, so bilateral PCN is there, so there is nothing which is coming down, and uh, patient will come in another 7 days. We will see. So
No,
now,
sir,
how many days? Yeah, tell.
diverting urine proximal to the bladder may not help in healing the fistula if bladder itself is pathological.
Fine.
If that perforation is due to a pathological bladder, that may not heal.
Okay.
So in such situation, what sir also telling and what we also routinely doing at general hospital, you better go ahead aggressively, excise the part of that particular perforation site, some edges, refreshen it, close it, and place the SPC. Two spontaneous perforation I have treated till time without any cause, and the histopathology is there is inflammatory interstitial. There is interstitial infiltration of multiple neutrophils and polymers. No diagnosis. That is the histopathology report of biopsy.
Fine. So idea is the same, that after 2 to 3 weeks, when the wound, everything, the abdomen becomes quite okay, the wound becomes okay, we will again give him a trial, and if see whether there is a leakage or not. And if there is a leakage, immediately when the abdomen is clean, we go do the exploration and do the suturing again. Is it okay, Gnanendra ji?
Yes, sir.
Okay. Fine. So this is, but later on, once this is settled, now next what we should do for reflux?
I think so. DMSA has not been done, so that.
They showed a DMSA 24% function.
Oh, okay.
20%, yeah.
In that case, I think it merits a reimplantation. In this case, high-grade reflux with the compromised function, with scarring. That along with the before that, I'd like to do a cystoscopy, rule out any other obstructive pathology because of the bladder perforation. Any bladder dysfunction should be ruled out before going ahead with the reimplantation. So urodynamics and cystoscopy I'd like to do before proceeding.
So Tanmay, is it possible that initially there was no reflux and later on it was showing reflux? It can be secondary to infection.
Yes, very much likely. But in that case, the infection has increased in severity by the time we did.
So suppose if we treat the infection, now in this case, now there are two questions. When you explore and when you do closure of the bladder, you will do that alone, or you want to do reimplantation of ureter, or you will want to do the closure, wait, again see whether there is infection and reflux, and then do the reimplantation of ureter.
So when we are going in for the closure, even if we have eliminated all like confirmed lack of infection, even then that won't be a clean surgery. So I would not like to do a reimplantation in the same setting in that case. So I'd like to close the bladder, ensure a sterile urine for a few months, and then maybe after that go for a reimplantation, because under antibiotic cover all this time, with continuous antibiotic prophylaxis all this time.
So if you close the bladder, everything is fine. Now you treated him for the infection. There is no recurrent infection.
Yes, sir.
Still, you will like to do reimplantation of ureter?
Because there is already compromised renal function and scarring, to save the whatever remnant function is there in that case, I would prefer going ahead with the surgery. Or
Right.
in that case, I'd like to do a redo VCUG to see if with the subsiding of infection, any high-grade reflux is there. But then considering the lack of function, I would still prefer reimplantation.
ज्ञानेंद्र जी, आपका क्या view है?
Sir, once this wound has healed, I would keep this child on chemoprophylaxis, bladder relaxants, and would not even think of reimplantation for the next 1 year. The situation inside will be so bad कि वो बेचारे का दूसरे एमसीयू में तो ब्लैडर परफोरेट हो गया, अभी रीप्लांट करने गए तो बैंड ही बच जाएगी.
Exactly.
या नाउ
I 100% agree with you.
या तो उसको तो हाथ ही नहीं लगाऊंगा मैं. Secondly, Tanmay, if because so far you have answered very well, so let me ask you something more. Have you heard of a review trial in reflux? It's a very large trial conducted.
Yes, sir. I mean, I've read about it, but I don't remember the details.
Yeah. You should know what are the basic things that were deciphered from it. I don't remember it exactly, but see, it will reimplantation. अगर अभी now before that, आपने कहा कि because the function is less, you want to reimplant. Will the function improve?
No, sir. It will only prevent the further worsening.
So occurrence of further damage may be prevented, but this will occur only if you are sure that further infection is being prevented by a reflux surgery.
Yes.
Now, because this bladder has behaved in a very odd manner, we need to let it settle down. It's an angry organ. Let him settle down. Uska gussa shant hone do. Reassess the capacity. Keep the child on chemoprophylaxis. And one thing which you mentioned, which I might contemplate doing at a later stage, not in the next 6 months to 1 year, would be a urodynamics. If at all the child is symptomatic, has symptoms. See, there are two things which are odd in this entire thing. One, because when the child initially presented, nobody knew what was the bladder bowel dysfunction, whether there was some dysfunction which was present or not. Second, it's very unusual for a child who had an first episode of fever with UTI to present with Pseudomonas infection. This was the second very odd thing. And third, it's reflux. First MCU was very good MCU done. It fulfilled every criteria that an MCU needs to be done, has to be done in a proper way. It had fulfilled all those criteria. It did not show any reflux. And the second MCU, which created all problems with bladder perforation, shows a reflux. So there is something which is missing in the entire scenario. And when he is going to come back, things, if it is nearly 6 weeks, by the time his nephrostomies are in place, you are now going to face a problem of a defunctionalized bladder. So maybe clamping of the PCN and then assessing the things over a period of time. So this is again going to take another 2 to 3 weeks.
Yes, I agree.
This is a long battle.
So, Ganesh, what I am planning is that I will, after once he comes, everything heals up. I'll put a Foley's catheter and gently we will put about 100 cc or 150 cc gently in the bladder and see whether there is a still leakage or not. Correct?
Yes.
And if there is a leakage and everything is okay, better to go and do the surgery and keep the DJ stent?
No, sir, I won't keep a DJ.
Right. So just close the nephrostomy, stop it,
Yes.
and let the
Sir,
urine come
wound
down.
has healed. I would clamp the nephrostomy.
Okay.
Assess him over 1 week. No
Okay.
leakage. Things look fine. Be very
Fine.
aggressive. I would be very aggressive in treating the infection and stabilizing the bladder with bladder relaxants to an extent that even if he has a bit higher amount of residual urine, say 40-50 ml, doesn't matter, but
Mm.
this leak should stop.
Yeah. So we have given him a very good antibiotics IV. Almost 7 to 8 days he was on in the hospital only, and so we have treated him quite well. But still, I will again do all the investigations, find out whether there is any infection, treat him again aggressively, and then claim their nephrostomy. Fine. Gitaji, Maheshwari, you want to add anything? Some suggestions?
No, I think fair. We have to give it enough time, wait, let things stabilize, clamp the nephrostomy tube, let him void properly, and then remove the nephrostomy tube. Stent definitely not needed because if the normal passage opens up, the abnormal offshoots will seal off on their own. Definitely no reimplantation in this patient for a long time. Just chemoprophylaxis and observe will be the way to go because doing a surgery again in the bladder now will be a very, very difficult proposition.
Yes.
Sir,
So
I would advise all the students that if you are likely to get a case of reflux in your exam, so you should know about the RIVER trial. You should know what is high risk VUR, what is moderate risk VUR, what is low risk VUR. So these things are needed. I think you people end up reading the guidelines also nowadays.
yes, all of us.
Yeah, so if you read these guidelines, EAU guidelines, I think you will get a fair idea. Even if your exams are near, you don't go through the entire one, but उसके जो main summary है और recommendations रहते हैं, that will give you a good insight into what needs to be done in most of it.
Good. Gitaji, you want to add anything?
No, sir. Just I am 10-15 minutes is not in the discussion. So probably it's going well.
Fine. So now we know when the patient comes back, exactly what to do, and we will let you know what happened and what we have done. Definitely only the closer, nothing more than that we will be doing. We'll wait, as Dr. Pankaj Maheshwari and Sharma just said, at least for 1 year. And meanwhile, we'll give good prophylactic, means antibiotics, and wait and watch. Fine. So, do we have time for small case, short case, or we end here?
One short case would do.
कर
Fine.
सकते sir.
कर सकते हैं.
Okay. Fine. Because today is the last case day for the case presentation. Fine. Okay. Go ahead. Swastik.
Sir, a 5-year male child presented with hematuria, with the complaints of hematuria. Should I go ahead or?
Yeah, make
Yeah,
it a
go
short.
ahead.
So hematuria was intermittent throughout the maturation, was not associated with pain or clots. There was no history of fever. There was no history of previous catheterization and instrumentation in the child.
Yeah.
So gestation birth history. नहीं. So there's
normal.
past history of bilateral undescended testis and history of bilateral stage orchidopexy in this patient, sir. So general examination normal, sir. Per abdominal examination was There was wrinkles present on the abdomen, distended lax abdomen, centrally placed umbilicus. Respiration was normal, and there's no visible swelling of peristalsis or pulsation. External genitalia circumscribed, and on palpation there was a lax anterior abdominal wall, and no palpable, no previous surgical scars, laparoscopic surgery scars were present, sir. This is a history. This was a prescription of the patient, and he had undergone multiple ultrasonographies. So initially, in 2018, there were dilated tortuous ureters on the both sides. Midline superficial cystic lesion was seen over the bladder, which was 2 into 1.8 centimeter in size, with no solid component or septations, and it was of uncertain nature. Then a DMSA scan was done in 2019. Left kidney was having reduced tracer uptake and no upper pole, and reduced uptake. Upper pole had no scars. Uptake was 58.1%. Right kidney normal, and 54. Sorry, left kidney uptake was 58.1%, and right kidney uptake was 41.9%. Then in an ultrasound done in 2021, midline superficial cystic lesion was above the bladder was not seen, and in an ultrasound in 2023, a grade 1 hydronephrosis on the right kidney was seen, sir. He has a history of laparoscopic bilateral first stage orchidopexy in 2022 and 23, right? Second stage orchidopexy and laparoscopic left second stage laparoscopy was done, sir. This was the X-ray, sir.
Fine. So, Tanmay, looking at all these things, what diagnosis probably comes to your mind?
Prune belly syndrome seems likely, sir, with a lax abdominal wall, bilateral and distended testicles, multiple urinary tract abnormalities.
So, what are the? Can you just tell us something about prone belly syndrome? And anyway, what may be the cause of hematuria? Normally, do you see hematuria in prone belly syndrome?
No, sir. No, sir.
But in this patient, there is a hematuria.
Maybe a superimposed infection, cystitis could be a cause. Because frequent UTIs are a feature of prone belly.
He has undergone some surgery.
Yeah, bilateral orchidopexy he has undergone.
Yeah. Can that cause? Okay, fine. Achint is there?
Yes, sir. Yes, sir.
Yeah. So can you just tell something about prune belly syndrome? I know you have read very well.
Sir, prune belly syndrome, also known as triad syndrome, Eagle-Barrett syndrome, or abdominal musculation syndrome.
Can you go a little slow so that everyone can hear it properly?
Yes, prune belly syndrome, also known as triad syndrome, Eagle-Barrett syndrome, and abdominal musculation syndrome. It's known the triad syndrome is the name triad syndrome is given because of the triad of urinary tract abnormalities and undescended testes and the absence of abdominal musculature. There are multiple theories regarding it. One theory is yolk sac defect theory. Other is the failure of closure of the lateral plate mesoderm theory. And one more theory is that there is obstruction of the urethra in early development, but later on the urethra canalizes well, but the permanent effects of the obstruction remain behind, leading to all the genitourinary problems. It occurs in 95% of the males and only 5% are female. Presentation is almost the same, only the females lack the gonadal problem, like the undescended testes which is seen in the male. Then, sir, there is a long list of abnormalities which are seen. Should I tell?
Yeah. You can go ahead, little more.
Yes, sir. Coming to the abnormalities which are evident in prune belly syndrome, I'll start from the upper tract. The kidney shows variable grades of hydronephrosis. There could be associated PUG obstruction with dilated ureter, with a simultaneous presence of ureteric stenosis in between. There could be the psychoureteric stenosis. Coming to the bladder, there is a large dilated bladder, but it is smooth walled, and there is lateral splaying of the trigone with the decrease in the number of alpha 1A receptors, which leads to the dilated bladder neck, sir. And coming to the posterior urethra, it's very much dilated. Prostate is hypoplastic, and seminal vesicle could be atretic or could be present, and similar stands for vas deferens. Then coming to the anterior urethra, it could be a megalourethra, it could be a trachea, it could be a stricture. There are variable presentations. There is a long spectrum of it, and among the megalourethra, it could be scaphoid variant or the fusiform variant, depending if corpus spongiosum is atretic, it's a scaphoid variant, or if corpus cavernosa along with corpus spongiosum is atretic, it's a fusiform variant. Then, sir, coming to the abdominal problem, there is lack of medial and inferior muscles, and the abdomen is hence composed of only skin and peritoneum only. There are no muscles in the medial and inferior region, and that's why patient usually presents with the wrinkled skin, or there could be abdominal bulge because of a wide hernias. Then, apart from these genitourinary, abdominal, and urinary problems, patient also has a spectrum of other systems involved. The cardiac vascular system may have atrial septal defect with ventricular septal defect or idiopathic ductus arteriosus. The pulmonary system may be hypoplastic because of the increased abdominal space occupied by the urinary system. Then there could be musculoskeletal problem, including autoamputation of a limb, and oligohydramnios may be present. It's present, and the
Fine.
treatment may.
Yeah, now let us come to this. So, okay, Tanmay, can you just describe whatever you are seeing?
So it is a delayed film of a contrast enhanced CT of the abdominal pelvis. So here we can see a grossly dilated and tortuous ureter seen on the left side with significant dilatation of pelvis, which is not extending to the major or minor pelvises. On the right side, there is again a gross dilatation of the renal pelvis and dilatation of the calyces, along with the dilated tortuous ureter. On the left side, there is more dilatation of the calyces and tortuosity of the ureter.
Yeah. Fine. So you are able to see most of the thing, correct?
Yes.
What you
Yes.
see in the prone belly syndrome.
Yes.
Only thing is, even if you see the first film, you can see the abdomen also when he's passing urine. You can see the abdomen, which is very lax.
Lax.
Yeah. Okay. Fine. So we are till now, Gyanendraji, you want to add something to help them
No,
in
sir.
prone belly syndrome?
No, sir. Achint has really given a good description of a not very common entity.
Yeah, we thought so. That this is not very regularly seen, and this was very atypical case with hematuria, a very interesting case. So thought of presenting. Okay, fine. So what was the cystoscopic finding?
Yes, sir. There was a growth on the ankle.
Yeah. So what was there?
So there was a granulomatous growth, sir, in the bladder, sir. And in this case, sir, we did a from the suprapubic incision, we inserted nephroscope and then removed the growth, sir.
So what was the growth?
The histopath of the growth came. So histopathology of the growth came out to be a vascularized granulation tissue with occasional foci of mild chronic inflammatory infiltrate. No granulomas were seen in this, and no ATP or malignancy was seen. So most likely a suture granuloma or a foreign body granuloma can be a cause, sir.
Okay.
वहां पर सुचर क्यों लिया?
Probably, we are not sure, but while doing the second stage, or while bringing down the testes, um, they might have taken up the bladder, because the abdominal wall was very lax, and bladder also might have been pushed down. Probably that is only we can think of.
The common cause for hematuria in prune belly syndrome is usually infection. One. Another is whatever the picture that mass is, that may be sometimes cystitis glandularis and or inverted papilloma. These are some few.
But you can see, this is something atypical. Can you see? It is coming from outside the bladder and entering inside, and it's not a typical growth.
सर सुचर लाइक थिंग तो हाँ कुछ दिख तो नहीं रहे, लेकिन ग्रोथ है डेफिनेटली. इशू इज कि वो ऐसा पिक्चर बहुत बार सिस्टाइटिस ग्लैंडुलरिस का रहता है सर, मिमिकिंग द मैलिग्नेंसी.
ओके.
सिस्टाइटिस ग्लैंडुलरिस एज में रहता भी, ऐसा कोई नेसेसरी नहीं कि उसके लिए कोई सर्जरी, और दैट इज अनदर प्रीडिस्पोजिंग फैक्टर फॉर हैविंग अ सिस्टाइटिस ग्लैंडुलरिस की प्रायर हिस्ट्री ऑफ सर्जरी.
या
तो हो दैट इज पॉसिबिलिटी. मेरे ख्याल से शर्मा सर और कुछ एनलाइटन कर सकते.
नहीं सर, हमने तो प्रून बेली अभी सोचना पड़ता है ना कि कब.
नो, करेक्ट. नो, वी हैड दिस
रूटीन तो नहीं है, लेकिन
something has happened while doing a laparoscopy, definitely possible.
Just keep it in mind. This we are keeping in mind. Something might have happened. Actually, this case is belonging to.
Swastik, can you read the CT report?
Yeah, Swastik. CT report.
So the last paragraph, sir.
Okay, read it slowly, with a proper clarification. Read it nicely.
Sir, the impression of the radiography revealed that diffuse marked dilatation of bilateral ureters with normal caliber of ureter just proximal to UV junction, minimal fullness of bilateral calyceal system with mild dilatation of the bilateral renal pelvis, diffuse bladder wall thickening suggestive cystitis, and a linear enhancing tubular structure within urinary bladder extending from its left anterolateral wall into the left inguinal canal. Is of indeterminate etiology and needs further evaluation.
So probably it is entering into the inguinal canal. So that is why we thought that some foreign body entering inside the bladder from outside. So during the surgery only something must have happened.
Yeah, very much possible.
I agree.
So this is a nice case. I think with this, all those who have attended, prune belly will be very clear in their mind. And if they listen to this clinic again, definitely they don't have to go and read into books again.
Gite sir, any idea about Woodard's classification tha na? There is something I don't remember now.
Achin, do you know about that?
Sir,
yes, sir. There was a category 1, 2, 3 Woodard.
1, 2, 3 category.
I don't remember the details.
Sir, I don't remember. Category 1, they all die. Category 3, you don't have to do anything. Category 2 are the ones which need management. That's all that I remember.
Achin, I think you had explained us. You can tell us.
Sir, actually, there is a classification, category 1, 2, 3, which is on decreasing order of the severity. With the category 1 people having maximum renal problems, including renal dysplasia, and these with urethral atresia and many other multi-organ system involvement. And these kids eventually die in a few months. So only conservative management is planned for them. Category 2 it requires the maximum intervention with moderate to severe dilatation of the pelvic helical system and the ureters and the bladder, and vital undescended is present. And the category 3 is the least severe form with only the lesser problems of the spectrum.
Yes. They require only follow-up.
Follow-up and only symptomatic management.
And maybe orthopexy.
Yes, orthopexy and later paternity. Actually, no prune belly has spontaneous paternity. I forgot to mention.
That category 2 and 3 are, one is less, na?
One is worst.
One is
One
worse.
is worse.
One is worst, but that is incidence is less, 20% near about, and 40, 42nd and third. That's what I remember. Exactly, I'm not recollecting, but
Yes, category
second
1
and third.
mostly dry in uterus.
Yeah,
Okay.
fine. So now with that, we know also how to follow up. That also has indirectly been explained. Correct? So if it is a type 3, then we have to just conservative line of treatment and just follow up. And the maximum aggressive treatment is in the type 2.
Yes.
Yeah. So anything else, if anyone can remember and want to add before we stop here? Achint, you want to add anything? Because we have read
No,
quite
sir.
a lot about Prune-Welly syndrome.
नहीं सर ये पूरा complete हो गया. बाकी
Yeah.
there are details about the abdominal myoplasty and all those.
So what is that? If you can just finish in next few lines. So before we close.
Different techniques are there, sir. Montfort technique, Dennis technique, Voorhees technique, which is a technique used to reconstruct the abdomen, in which there is a very large bulge of the abdomen causing problems.
Okay. And what they do for bladder and what treatment they do for the hydrouretronephrosis?
So depending on what system is involved, it's the PUJ, we have to repair that. And if the large megaureter VUR is there and the bladder is normal, it's non-neurogenic, then we have to do reimplantation. It's as per the symptoms. If it's on the other end, the serious end of the spectrum, we have to manage. And in the lesser end of the spectrum, we have to give a conservative trial.
And if it is a neurogenic bladder, we have to treat it as a neurogenic, means whatever normally we do in neurogenic bladder, correct?
Yes, yes.
Okay, fine. So Maheshwari ji and Ganesh, you want to add anything?
Nothing, sir, nothing.
No, nothing from my side also.
I think this was a nice case just for the
Yes.
discussion and presentation.
Absolutely.
Right? Okay. So now we meet after 15th of October. Then this time now we'll start with the OSCE, and so that it will include the small the thing short case presentation, all the tables, viva, and the board rounds. So till time, all the best to all the students who are appearing for their final exam. Okay.
All the best, sir. Good night.
Okay.
Good night.
Best of
Good
luck.
night.
Thank you,
Good
sir.
night.
Good night. Good night, sir.
Good night, everyone. Bye.
Bye bye.
Sir, Pankaj sir, kindly end the session.
Yeah, I'm doing that.